I have done a fair number of talks, a fair number of speaking engagements. I have never followed vaginal itching. Definitely new territory. Although I did figure out that the number you were talking about, telling patients not to wear garments that irritate them, and I wonder if that explains the number of patients that walk around without underwear on. When you go to examine them, and you're like, there's nothing back here. Those are rough jeans. So, mostly males, I'm not sure how that correlates. But anyways, kind of covered my intro. I did pain management for a few years in South Carolina, and then fortunately got recruited here, and so just fortunate to be in this area, fortunate to be involved in the system, in our practice. Dr. Chapman, our senior partner there, has done an amazing job setting up the practice, and just glad to be a part of it. So that's my team there. That's my wife Sarah, our newly 6-year-old Ella. Recently, so you can tell what we're up to. A little bit about our practice. Dr. Chapman, he started the practice, I don't even know how long, probably 15 years ago, something like that, 15, 18, something like that. And he is, our pillar here in Mountain Home, and then myself. We have a clinic up in West Plains, Missouri. I go up there on Wednesdays, and then we have Jessica Dwyer, one of our nurse practitioners, goes up there a couple days a week. And that is slowly growing. Anybody that goes up to West Plains, I know Dr. Knox does. It's a unique environment up there, but we're doing well. And one of the other practices up there in West Plains, the pain management practice, is actually one of the physicians is actually leaving, so we're going to be hitting a growth spurt up there, which will be good. And then Dr. McNelly is here in Mountain Home with us, and then goes to Harrison, Arkansas. We have the new facility over there, thanks in part to Baxter, as far as getting that set up. So we've really been, things are going well over there. And then probably one of the more exciting things for us, and nerve-wracking and anxiety-inducing and everything, is that we got 2 new physicians coming on. It's always challenging to recruit a physician, and we had 2 really strong new fellows coming out this year, and one of them is from Dallas, Texas, and she'll be joining us in August. And then we have another one from, he's coming up, he's the only pain fellow in Little Rock there down at UMS, so he's going to be joining us in September. So that's kind of our new exciting thing. I mean, we just from a volume standpoint, and Dr. Chapman's trying to scoot back a little bit and ease off, so it's really exciting for us. So Dr. Slepica and Dr. Price will be joining us summer to fall, so that's pretty exciting. And then we have Jessica Dwyer. She's one of our nurse practitioners, and she, as I said, goes up to West Plains on some of the days, and then Stephanie Smith and Mackenzie Lively, both here in Mountain Home, and then Mr. Munn there is in Harrison, Arkansas as well. So what in the world do we do? That's, a lot of people think of pain management. A lot of the patients, they come in and they're resistant to come to see us. They think for whatever reason, they're just resistant. Either they read our reviews online, or no, I'm just kidding. Well, not really. Our reviews are colorful. If you ever want to see unhappy patients, find some pain management patients that don't get what they want. It'll provide you with some entertainment. But they think that we're just pills. That's kind of where we a lot of people think, does pain management, I don't want pills. There's a lot of them that do, but some of them, a lot of them are kind of resistant to that referral because it's that unknown, and they think we're just going to dope them up and kick them out the door. But certainly that's not our plan. That is a portion of what we do, certainly with medication management and all the new stuff coming down the pipeline and the new criteria and the new standards and the, and then the challenges from the lack of opiates that everybody's dealing with now, and patients not being able to get prescriptions, and they go to the pharmacy and they don't have them, they have 4 pills, and it's just that whole end of stuff is certainly a challenge, but so we're pretty good at working through that from a medication standpoint, so we do our best there. As far as the addiction stuff, Dr. Chapman, as it says there, he's the only board certified addictionologist in North Central Arkansas, which is a pretty big deal. I think there's only 6 of them in the state of Arkansas as a whole, so he definitely brings a lot of knowledge there, just from his wealth of experience, but also that additional training and board certification. So we do the suboxone. He does the suboxone. So that's I'm sure most everybody's had at least some exposure to that with patients. I know, a lot of OB patients are, end up with that for a variety of reasons. And then recently he has started doing what's called Sublocade, which is a injectable suboxone, essentially. It's kind of like a depot shot that just releases it, and I think it's good for a month. So that is a new option. So you take away some of the advantages of suboxone on the streets by doing that. So that's another avenue. As far as interventional procedures, I think everybody knows we do a lot of epidurals for the radiculopathies. As far as we do a lot of peripheral nerve injections. Some people may not realize that. Occipital nerve, there's something on the body we've probably injected it between toes and scalps and ears and TMJs and fingers, and we do a lot of that stuff that just people deal with, and I enjoy doing the non-spine stuff because a lot of times people respond better. The spinal stuff is a lot of times more chronic and certainly more challenging. We do radiofrequency ablations of the cervical spine, lumbar thoracic, and then we also do genicular stuff for the knee patients that either aren't knee replacement candidates, or they've had a knee replacement that hasn't gone well. Obviously not yours, Dr. Knox, but there are those patients that so we have a lot of success with those. Spinal cord stimulators, we do a ton of those. I do a ton of those. Again, it's a challenging patient population, as I'm sure I don't have to tell anybody here that's dealt with any of these chronic pain patients. Spinal cord stimulation can work really, really well for a lot of people, and it can fail miserably for a lot of people. And those patients, I don't care what you do for those people, they're probably not going to do well. So, they're just challenging. So, and that's the spinal cord stimulators. Fortunately, we get to do a trial with those. So we do a 5-day trial with a temporary device, so we can at least get some idea how they're going to do. But extrapolating off of a 5-day trial, how they're going to do for years is certainly has its challenges. But peripheral nerve stimulators, probably most of y'all aren't familiar with those. Basically, that's we'll take a lead and put a little electrical lead like a spinal cord stimulator, but we will do it obviously peripherally. So we can do it for shoulder pain, suprascapular nerves. I've done them for femoral sciatic, people that have weird neuritises. They've had some type of nerve damage. Shoulder pain after they've had shoulder surgeries. They're not a candidate for a total shoulder. They've already had knee replacements, stuff like that. So there's a lot of cool stuff like that from a peripheral nerve standpoint. We haven't been doing those real long, so you may not have seen them. The device that I use is actually just a temporary device. So we'll put that lead in, and then they wear a small, almost like a diabetic monitor, like a little stick-on battery, and it stays there for 60 days, and at the end of that, it comes out. Purpose being, and kind of the theory behind it is that it kind of burns out that brain connection, because it provides that stimulation in your brain. After a little bit, says this is, it almost overstimulates, so your brain kind of down regulates that input, and that pain resolves. And at the end of that 60 days, that device comes out, and I've had good results with a lot of patients with those. So it's pretty cool to see, because a lot of those patients have been challenging with the weird neuropathies, and so that's been a newer kind of exciting development. EMG, nerve conduction studies. Dr. Price, who's joining us in August, she will be doing those for us. Not exactly sure, but hopefully in all 3 locations. So we're pretty excited to have a physician that can do those studies locally, because it is certainly a complex study. You can provide a lot of information. It's just, sometimes challenging to get those. Prior to her being here, the only physicians that were doing them were either Dr. Applegate up in West Plains, or you're going up in North Central Arkansas. So we're really excited to have her on board doing those. From a surgical standpoint, we do the spinal cord stimulator implants again, kind of feeding off of the trials that we do. So we do have a lot of success. If you see these people and they're not happy with them, the first question I would ask them is, when's the last time you were reprogrammed? Because these are devices that do require some programming, some maintenance, some care along the way. And the number of patients that I've seen that have had a device implanted, most of the time it has happened, because I kind of try to stay on top of that, and our reps are really good, but they've had it implanted in Springfield in Northwest Arkansas, and they'll come in and say, well, no, I had it put in, I never had a reprogramming, and the odds of having any success with that are essentially 0. So those are important things. And then always, just if they got a device like that, get them hooked up with us, and make sure we're maximizing the benefit from that. Kyphoplasties, I do those. That's probably one of my favorite surgeries to do, honestly, because the patients do really well, and it's one of the few things in pain management where it's pretty gratifying, like right away. By the time they make it to post-op, very few things in my world are like that. So, they, as most of you know, time is of the essence for that, as far as vertebral body compression fractures. They have to have 25% compression in order to be a candidate for kyphoplasty, and obviously they have to have symptoms consistent with pain from the compression fracture. But if you have those patients, if you have compression fracture patients, just call us. I'll get them in within a day or 2, and we'll get them seen, and hopefully get them that surgery within a week, because those patients, a lot of them, the osteoporotic patients, these people, they decline really, really fast, and if you wait, generally that's 6-8 weeks beyond the initial injury, you get out beyond that, it's going to be challenging to do that surgery, and then the results are definitely mixed, and so time is of the essence with that one. And I just think it's a fantastic procedure. It again really does well. I had one of my favorite stories with that. I had a patient in South Carolina who had a compression fracture. Her husband brought her in, and she was severe dementia, had no really kind of wherewithal there, and she had a pretty nasty compression fracture, and I just did not want to take her to the OR. I fought it for a couple weeks, and her husband was pretty adamant about it, because she was just laying down doing nothing. And so I decided, I took her into the kyphoplasty, saw her for post-op, and she had no recollection of the surgery, nothing, but she woke up that next day and she took up right where she had left off, and she was walking, doing everything, and I was like, about as good as a case study as you can get, because she was double blinded to herself. So, I mean, where are you going to do that? So it was pretty remarkable. So, kind of ever since that, honestly, I've been a big believer in that procedure. So again, please just, if those are the cases, and we take care of everything as far as, you know, I see them, set them up, do the surgery, and then see them for follow-up. So that we'll make it happen, and we'll make it happen quick if they're a candidate. Mild, it's actually an acronym, minimally invasive lumbar decompression. These are patients who have spinal stenosis with neurogenic claudication. So all these people you see at Walmart kind of walking around like that, or holding onto that shopping cart, the shopping cart sign, where they're leaning over, because what that's doing is opening up their spinal canal, and they can't stand long, they can't walk far, and they get that pain in their back and butt and kind of radiating down their legs. Usually they're pretty easy to identify, so that neurogenic claudication. There are situations where it can be vascular claudication, and those are the scenarios where we'll have vascular work them up and just make sure, because the symptoms are very similar. Kind of the poor man's test for that is if you put them on a recumbent bike, if they have something available, and if they're pedaling on a recumbent bike and their symptoms replicate, then it's a vascular claudication thing, because they're in a flexed position on a recumbent bike. So that's kind of, I've done that with several patients. It's kind of that workup. It kind of helps you if they have access to that bike. So, so I have a slide in a second about what exactly that is, and then the Vertiflex is kind of a newer thing coming down the pipeline as far as we're concerned. So as far as the kyphoplasty, that's the gist of it there. We're putting trocars into the vertebral body posteriorly, so they'll have two small incisions. And then the difference between just a regular vertebroplasty and a kyphoplasty, the kyphoplasty is actually a balloon kyphoplasty, so we're blowing up that balloon in there and creating a cavity. And there's also some thought that the balloon kind of walls off that fracture and creates a cavity in there, so you can be a little bit more certain, because the risk always with these types of surgeries is that you get some movement of that cement outside of the vertebral body, which is bad, especially if it goes posterior into the spinal canal. So that we just blow it up under fluoro, do a balloon on each side, see where those balloons are going, deflate the balloons, and then I'd say this slide probably exaggerates it a little bit. You don't get a ton of vertebral height restoration, and honestly, if you get it, cool. You're probably not going to. It is more to do with just stabilizing that fracture. And there's two things that happen. You have the cement, which goes from a liquid to a solid, which is inherently a exothermic reaction, and so there is some thought that in and of itself kind of fries those nerves in there, and you get some pain relief from there as well as from the fracture stabilization. So again, it's one of my favorite things to do from a surgical standpoint. So you get those people in when you can, when you see them. This is actually the Vertiflex device. It's a newer device. Some of you may have been familiar with it was called the X-Stop, and that was a number of years ago. It kind of flopped a little bit. It was similar in nature, but the idea being with these devices, we actually just make a small incision posteriorly and then go in between the spinous processes and essentially kind of jack the spinous processes apart. And what that does is it opens the foramen on the sides, and it also it kind of tilts that spinal canal a little bit, so that it opens it up a little bit more too with regard to the central canal stenosis as well. So again, that can be a good option for people that which most people don't want to undergo a large spine surgery. This doesn't take away that potential in the future, and that's one of the reasons why with the mild and the Vertiflex, you know, the neurosurgeons, they are sending patients to us, and you know, and they send us the kyphoplasty patients too. I mean, we're doing those. So, so if these are patients that may not be ready, or if they're telling you, I don't want to do a big spine surgery, I mean, those are patients, get them to us, we'll explore options, and then, you know, obviously we work very closely with the neurosurgeons, and, you know, if it comes to that point when they need a bigger surgery, we've got them teed up for them, and they can get it done. So, so this is another minimally invasive option that may be an option for some patients in certain situations, the ones that have moderate spinal stenosis and the foraminal stenosis. So that's an option. As far as the minimally invasive lumbar decompression, what I'm doing with that is I'm going in and my mouse moved up there, yeah. Using a small instrument, in coming in, and we actually thin out the ligamentum flavum here, which kind of buckles and pinches in on the spinal canal as people age, and as the disc height lessens, that ligamentum flavum kind of kinks up into there. So we're able to just make a small incision again and go in, thin out the back part of that that ligament, and this is probably an exaggeration too, but I mean, it doesn't look that good afterwards, that's like new, but a lot of these patients, they're 80, 85 years old, they're walking hunched over. You know, I have a lot of patients that it may not seem like a big deal to us to stand for 5 minutes, but if you can't stand for 5 minutes, you can't shower, you know, and these patients are coming in, and they went from not being able to stand longer than a minute or two to standing for 5 or 10 minutes. Well, that's a whole new world to them. They can stand in a shower, they can do something, they can, you know, make it into Walmart to get to a shopping cart type thing. So, you know, it ideally is a more drastic improvement than that. But even in the situations where I'm able to do a surgery that takes me 10 minutes, 15 minutes, and get them, you know, that much improvement, it can be fairly substantial. And then, you know, risk profile, again, these are all outpatient surgeries. They're, you know, 15, 20 minutes, and they're walking out that day. A lot of times with these, the biggest problem I'll have for the first few days, because I got a little bit of steroid in there, just coming out, is keeping them down for the first few days because they get excited. And then spinal cord stimulation, a little bit more about that. Big indications: failed back surgery syndrome, post-laminectomy syndrome. Use the post-laminectomy syndrome when you're around the back surgeons so you don't offend them. And peripheral neuropathy, it's mixed. I mean, as you well know, as everybody knows, peripheral neuropathy is a bear to treat. With spinal cord stimulation, it is equally as challenging. It is an indication, it's approved, but you're trying to stimulate something that doesn't have feeling anymore, which is a, you know, inherently challenging situation. So, but that being said, we do have patients that, especially at night with those peripheral neuropathy patients, that they can lay down in bed, crank that thing up, and fall asleep their ass off. Cervical fusion and lumbar cervical radiculopathies, the indications have changed a little bit, so you don't necessarily need to have had a surgery for most insurances now in order to get approved for spinal cord stimulation. So they're able to, I think that thinking has finally changed and evolved a little bit. So if we can do a spinal cord stimulator delay, or, you know, at least delay a surgery, these patients are a lot of times better off. So other than that, questions, anything? Questions about medications, suboxone, Suboxone, injections, procedures, anything? Nope. Easy enough. All right.